Hi, my name is Dr. Timothy Willens, and I'm the Chief of the Division of Child and Adolescent Psychiatry and the Director for the Center for Addiction Medicine at the Massachusetts General Hospital and the Massachusetts General Hospital for Children. And I, by disclosure, also work with a number of compounds related to ADHD in a research capacity. I work with a group of researchers and clinicians, and have been clinically treating a number of kids and adults in a variety of different settings for ADHD for many years. And what I'd like to do today is to give you a viewpoint on ADHD for a pediatrician and to give you an understanding of ADHD not only in children but also in children as they transition to young adults and children as they move to become adults. So first, let's start with ADHD in the United States and get a sense of the epidemiology of this disorder. The prevalence of ADHD among 8 to 15-year-olds is about 6 to 9%. And what's interesting is if you look at the percentage of children who have been treated over the past year, it's about 25 to 35%. The epidemiology of ADHD in individuals who are young adults and adults is about 4 to 5%. And if you look at the number of those individuals who are actually treated as adults, you can see that that number drops off to about 10%. So it's pretty clear that we're pretty good at identifying and treating ADHD in children and adolescents, and we're much less good, so to speak, in adults who have the condition. The other comment I'd like to make about the epidemiology of ADHD is that the rates of ADHD are roughly the same in other countries, and we're going to come to that in a second. If you look at ADHD, it's also important to realize that it's associated with high degrees of psychiatric comorbidity, so that it's unusual that you have ADHD just alone. In fact, only about 25 to 30% of cases of ADHD are just ADHD. They often come with other disorders that we'll talk about a little bit later. And a point that you're going to hear me say over and over through this talk is that ADHD is not just a cosmetic disorder. It is associated with substantial impairment in multiple domains, and it tends to have a chronic course. And again, roughly 50% of kids will have the disorder. That's why 6 to 9% of 8 to 15-year-olds have it, and about 4% of adults have it. About 50% continue to have it into adulthood. So you can see that it's considered now a chronic disease. So let's go back to the epidemiology in terms of the worldwide rates of ADHD, which is the next slide. On the left, you can see the rates of the disorder in different states and cities, some of the major metropolitan areas. And you can see that that rate, again, falls typically between the 6 to 9% range. There's some that are a little bit higher and some a little bit lower. But in general, it falls to that range. If you look at the right, you're going to see that if you compare to different areas and countries, that the rates of ADHD are essentially indistinguishable from the rates in the United States. And why does this become important? It's important because we realize that anytime you see disorder rates, particularly in behavioral health, that are roughly the same in different countries, you at least start to develop a sense that it gives you a sense of this being a prominent genetic-based disorder, that there's a stability to the diagnosis and the rates of the diagnosis that exist in other cultures. It's not just a cultural phenomena of a busy society, for example, if you see these rates to be the same in other countries that may not have the same social construct as the United States. The next slide is a description of the heritability of ADHD in context to other disorders that we have a good sense of understanding that are highly or less highly heritable. Let me just remind you, heritability coefficients range from 0, where 0% of the variance can be accounted to genes, to 1, where 100% of the variance can be accounted for by genes. And these are twin studies that we're looking at, and they look at essentially concordance between twins. Height, for example, is a very heritable trait, about 80% genetic. Panic disorder, on the other hand, is less heritable, with between 40 to 50% of it being genetic. For ADHD, what I want to point out is how consistent the twin studies are. These twin studies, despite using very different methodology, rating scales, assessment, teacher report, parent report, et cetera, basically on average give a coefficient of heritability, that which is thought to be associated with genes, that's close to 80%. What does it mean? It means that if a patient has ADHD, the chances that the patient's ADHD is driven by genes is about 80%. As a reference, breast cancer is about 30%, asthma about 0.3%. So ADHD, among what we call polygenic illnesses that we contend with, is among the most heritable conditions in psychiatry. What I'd also like to point out with ADHD is that even though we think of the heritability of 0.75 to 0.8, that would still mean that about 20 to 25% of ADHD may be manifest by the environment. For example, in utero exposure to cigarettes creates an ADHD-like clinical presentation in the children born to these mothers. And that is something that is very preventable. So talking to mothers about not smoking while carrying their unborn child may help prevent the onset of new cases of ADHD. In the next slide, we looked at the suspected neurochemical pathophysiology of ADHD. Let me explain what you see. This is a synaptic cleft. You see a presynaptic neuron synapsing onto a postsynaptic neuron, which is at the bottom. Depicted here is a catecholamine neural system. And abnormalities in dopamine and noradrenergic systems, referred to as catecholamines, seem operant in ADHD. What seems to be occurring in ADHD is that you have dopamine or norepinephrine that generally migrates into and across the synaptic cleft, binds postsynaptically receptors, and then potentiates the signal. That norepinephrine and dopamine is then taken back up into the cell through what's called the transporter. It may be that with ADHD, there's abnormalities either in the transporter or in the amount of dopamine and norepinephrine in the synaptic cleft. In the next slide, you get a better sense of how do the treatments for ADHD work. In general, despite the busyness of this slide, what you see are that the different medications work by making more of the neurotransmitter, in this case dopamine or norepinephrine, available in the synaptic cleft. Some of the medications, such as methylphenidate, MPH, the active constituent of Concerta, Ritalin, Focalin, those medications binds and blocks the dopamine reuptake transporter. That is where the little X is that sits on the presynaptic neuron. And by doing that, it plugs the reuptake system, making more norepinephrine and dopamine available in the synaptic cleft to potentiate the signal to the postsynaptic neuron receptors. Amphetamine works similarly, but also gets into the cell, and it causes what's called a facilitated release. It releases norepinephrine and dopamine into the synaptic cleft, as well as disturbing the fascicular storage mechanisms. The other medications we have work, such as atomoxetine, by blocking the transporter, but the recycle mechanism, but only for norepinephrine. And we have the alpha agonists, clonidine and guanfacine, that work by blocking the alpha 2 and 2A presynaptic neurons, and by doing that, it attenuates release, as well as new data suggesting that alpha agonists also bind postsynaptically to the postsynaptic neuron receptors at the bottom to help also attenuate the signal. In general, most of the agents we have, and those that are in development that seem to be most successful, work by potentiating the neural signal at a synapse-to-synapse level. In the next slide, you're looking at a functional MRI scan in adults with ADHD. Within the past decade, a number of imaging studies using MRI or CT have demonstrated structural differences between the ADHD brain and a normal brain. The studies consistently show that the prefrontal cortex and two basal ganglia, the caudate nucleus and the globus pallidus, are significantly smaller in children with ADHD. In the study that you're looking at in front of you, that now is over a decade old, you can see that on the left are normal controls. An area of the anterior cingulate lights up when you ask them to do a specific neuropsychological test. On the right, given that same neuropsychological test, you have activation of a different part of the brain in individuals with ADHD. In fact, that's called the lateral prefrontal cortex or the insular cortex, a part of the cortex that is not implicated in general cognitive processing. So you're using other areas of the brain to process information. And by doing that, it's thought that this is less efficient, more cumbersome, and may be fraught with other types of impulses such as frustration and other that may be related to cognitive processing. Now, what's interesting and not shown here is that if you give somebody medication such as methylphenidate, what you do is you convert the picture from the right to a picture on the left. It actually resets the parts of the brain that then are operant in ADHD. So not only do you have a response to treatment, but you actually see an improvement in the brain functional imaging so that you look more like a non-ADHD, quote, normal adult if you're treated with a medication that we know is effective for ADHD. There are a lot of questions, and the next slide helps to address this, about the effects of psychostimulants such as methylphenidate, Concerta, Focalin, the transdermal patch, or amphetamines such as Adderall, Adderall XR, Vyvanse, Dexedrine, on the development of the cortices. And in this study, what I want to point out from the NIH is that you have on the left a group of individuals that are at early adolescence, 12 and a half years of age, and followed for 4 years. This group included 3 different subgroups. One, a typically developing cohort of children without ADHD. You then had a group of ADHD that were on psychostimulants and another group of ADHD that were very similar who were off psychostimulants through this period of time. And if you can look at the side on the right, time 2 with a mean age of 16.4 years, you'll see that the group off psychostimulants actually had less brain thickness in the cortices compared to those on psychostimulants, and that those on psychostimulants actually look closer to the typically developing cohort. So when parents ask the question, what are the long-term effects of stimulants on the developing brain, we have moved from worrying about neurotoxicity to thinking about neutrality as we had better scanners and longitudinal data sets to examine this issue, to now thinking that there could be a neuroprotective effect of stimulants on the developing brain. And I'll say that there's been a series of recent reports and meta-analysis that confirm that finding, that what they're seeing is not neurotoxicity or problems with brain development, actually seeing what might be seen as a healing effect of psychostimulants or treatment for ADHD on the actual brain substance. And I think that's very comforting in terms of discussing this with parents of children who you're putting on these medications. Another issue that comes up is the issue around the effects of medication on later sequelae to ADHD. In the next slide, that looks at the protective effect of medication treatment on later comorbidity, is based on a longitudinal sample of 140 boys with ADHD at entry and followed for 10 years. These charts are broken up by looking at the development of a number of different conditions. Let's focus on the upper left, major depression, using a type of presentation called the Kaplan-Meier curve. Just to give you a sense, on a Kaplan-Meier curve, in this sense, the higher numbers would indicate more people are developing, in this case, major depression. Over to the left is the failure function, and roughly 0.25 is about 25% of the sample. So in the major depression upper left, you can see that those kids with ADHD who were on lifetime stimulant therapy, as depicted in the blue, actually had lower rates of major depression compared to those who never received stimulant therapy as depicted in the red. So in fact, stimulant therapy appeared to protect against the development of major depression. Similar findings were noted for multiple anxiety in the upper right, oppositional defiant disorder, which is considered the defiance, disagreement, annoyance by others, or being annoyed easily. That's very frequent with ADHD. Again, those with lifetime stimulant therapies had much lower risk for oppositional defiant disorder than those who were not treated with stimulant medications. And finally, looking in the lower right, a proxy of academic functioning is repeating a grade. Approximately a third of kids with ADHD will repeat a grade. And here you can see that those kids who repeat a grade who are off psychostimulants were at much higher risk of doing this than those who are on psychostimulants. One important notation is that the groups were essentially identical in terms of severity of ADHD, family histories of problems, et cetera, and while we'll never know why do some people allow their children to go on to psychostimulants and others don't, we know that these groups that were evaluated for this for these analysis were essentially the same, in that it was the presence of a treatment that helped reduce the likelihood of serious outcomes. Continuing on that same theme is the next study that was another Mass General Hospital study of adolescent girls with ADHD, where we looked at stimulant treatment and later substance use disorders. It is a major issue and a major concern for parents that if you're giving a child a psychostimulant, does that increase the likelihood that later they could have an addiction, because psychostimulants have abuse liability. And I'll actually circle back to that at the end. In fact, again, using a similar type of charting, those kids who were treated for their ADHD had lower likelihoods of developing a substance use disorder than those in the green who were untreated. And we have found similar issues with cigarette smoking, and we've shown this in multiple data sets. That's the good news. The bad news is most of the studies that are like these naturalistic studies, these are not randomized studies. These are just following kids naturalistically with ADHD and then asking about a number of outcomes as they age, have shown that while you see effects in adolescence, you start to lose those effects in adulthood. And many people speculate, and it appears from the rates of medication usage in young adults, that many kids stop their medication when they move through adolescence and into young adulthood. And not dissimilar from the story with antihypertensives and stroke. If you stop antihypertensives, the risk for a stroke related to hypertension will return. The same appears to be the case here. If you stop your medications, particularly during the ages of risk for substance use and some of the major other sequelae outcome, which is older adolescence and young adulthood, you can see that there's an increase, that the risk for those disorders go back up based on just having ADHD. In other words, we know that ADHD in general doubles the likelihood of having outcomes with depression, anxiety, substance use, cigarette smoking, and treating it appears to reduce that ultimate risk that ADHD brings with it. Another finding that's not depicted here, but again is important, comes from the Swedish registry study that shows almost a 30 to 40% reduction in crime associated with ADHD. And why that's a notable study, in that study, there were over 25,000 children enrolled in that study, half on medication treatment and half not receiving medication. Again, no big differences between those groups, but when those kids were followed through the age of risk in that registry study and reanalyzed, it was the group that were treated that had that 30 to 40% reduction in criminality compared to the groups that were untreated. Again, another indice of better outcomes associated with treatment. And the next slide, the consequences of not treating ADHD in teens is important because we talk about the risks and benefits of meds, and that's important, but I think what we need to do is also realize what happens if you don't treat ADHD. Again, it's not just a cosmetic issue. They have academic failure and or underachievement, and that predicts bad outcomes over time, low self-esteem. There's an increased risk for later antisocial behavior with delinquency, fighting, aggression, and legal consequences. Again, treated ADHD reduces that by 30 to 40% based on the Lichtenstein article in the New England Journal of Medicine. And then there's risk-taking behaviors. ADHD doubles the risk for a motor vehicle accident, and treating ADHD reduces that risk. And I would recommend to all individuals who are treating individuals who are driving with ADHD to have a discussion and document that discussion that ADHD increases the risk for a motor vehicle accident largely through distraction, that you should not be driving while you're using texts or cell phones or eating, talking to friends, doing things like that. You have to be very serious driving when you have ADHD. And number two is you should be treated for your ADHD also. Once you've had that conversation, document that in the chart that you discuss the risk for motor vehicle accidents and the need for treatment and to reduce distraction. Other things that are associated, again, we've talked about substance use, promiscuity, accidental deaths, suicides, and suicide attempts, and injuries. For example, I was recently at a talk where they were showing a big data set of treatment for ADHD, and what they found was that during the placebo treatment, the rates of just injury were significantly higher than during long-term treatment in a randomized controlled trial. Again, rather it's an issue of treating the ADHD that reduce the likelihood for bad outcomes and injuries. And when we extend this to real-life consequences of ADHD in the next slide in adults, you can see that if you're treating ADHD, you want to continue this. You want to have the conversation that this is probably going to be a chronic disorder if it's still around in an adolescent, that not treating ADHD compared to the control group results in less income. Some people estimate that there's anywhere from a $10,000 to $40,000 per year drop as these kids become adults. More high school dropouts, less college graduation, more problems with drug use, smoking, and addiction in general, more difficulties with employment, arrests, and interpersonal difficulties, almost twice the risks of being divorced. In terms of diagnosis of ADHD, the DSM criteria in the next slide for ADHD really are constituted by both the inattentive symptoms and the hyperactive and impulsivity symptoms. And we're going to start with the inattentive symptoms first. For children, you're going to need 6 out of 9 of these symptoms. If the child is 17 or older, you only need 5 out of 9. So that's a difference in the DSM-4 versus the DSM-5. The new DSM-5 has relaxed the rules a bit. And I'm not going to go through these in their entirety, but I just want to make it clear to you that what you're looking for is the child often and developmentally inappropriately, so compared to peer groups, fails to pay attention to details, has difficulty sustaining attention. Sustaining attention or vigilance attention is one of the biggest findings that you see, for example, over time. They don't seem to listen. They're spacing out. They're having problems following through on instructions and difficulty with organization. And I just want to hold on that one for a second, because following through on instructions and organization may be an issue of not comprehending what's told to them, or it may be an issue of what we call executive function issues. That is, that these kids have difficulty organizing, task managing, shifting, prioritizing, and that may be a separate cognitive difficulty that they have, almost like a learning disability. I only tell you that because that's the least responsive to treatment unless you use specific organizational types of therapy that can be helpful for that. The other is they can be distracted easily by either internal or external thoughts and are often forgetful in daily activities. So that's what you're looking for the inattentive symptoms. Shifting now to the next slide, the hyperactive impulsive symptoms, it's really 3 of the hyperactivity, 3 impulsive that sort of that are typical for kids who have these kinds of symptoms. Again, here's the list of 9 different symptoms. What you require is 6 out of 9 to make this subtype or class of qualifier of ADHD unless you're an adult and you only need then 5 out of the 9. And what you see here, either demonstrated in front of you when you're seeing the child or you hear about this, and you don't need to see it in front of you, you can be hearing about this, is a lot of fidgetiness, leaving the classroom or getting up a lot, running about, difficulty playing quietly, making a lot of noise, always feeling like the child is running around, talking excessively, blurting out questions, difficulty awaiting the turn, pushing in lines, interrupting or intruding on others. And remember that most kids are going to do a little of that when their parents are on the phone, but if they're constantly interrupting or intruding into others' conversations, butting into their friends' conversation, it becomes socially problematic for them. So the essential features of ADHD in the next slide are that you have either inattentive symptoms of ADHD or hyperactivity, impulsivity symptoms of ADHD, or you have the combination, which is actually most common in certain settings, where you have 6 or more of inattention or 6 or more of the hyperactivity, impulsivity, unless you're talking about a 17 or older, which in case it would be 5 symptoms of either. And you have basically count the symptoms. Remember, these are developmentally inappropriate, so you're going to see most 5, 6, 7-year-olds who have some degree of hyperactivity, impulsivity, fidgetiness. That's normal. But if you say a same level of that kind of those types of symptoms in a 16-year-old, that may not be normal. The persistence is at least 6 months. It's more chronic. It's present now before the age of 12, so they've moved the age up from 7 to age 12, particularly to capture adolescents and adults who may not have recollection before that. While it doesn't have to be better accounted for by another disorder, it can be made in context to those children who have developmental disabilities such as autism spectrum disorder, and that's a new feature of the DSM-5, the new diagnostic system that's just coming online. The other issue is it should be clinically significant and evident in at least 2 settings, although not always is it, but those are the diagnostic essentials for the disorder. In the next slide, I want to talk a little bit about the age-dependent decline of ADHD symptoms, and that is as kids age, parents may want to ask you what happens to the course of this disorder. And what we know from a number of studies is that the hyperactivity, impulsivity tends to diminish with time, whereas the inattention diminishes but still continues to be problematic. And that's what you see with this graph in front of you. The lines demarcate where there may be functional impairment to the point where hyperactivity, impulsivity up to the age of 18 just starts to not cause functional problems, whereas the inattention, while it's getting a little bit better, still is well above the functional impairment line, and often is still what we call syndromatic criteria. Still, because there's so much inattention, one can still make the diagnosis of ADHD. The next slide is very important because it talks about common co-occurring diagnosis with childhood ADHD. And this gives you the prevalence in children with ADHD. So to orient you to this, you have the middle, which is ADHD, and then you have things that are very common, such as oppositional defiant disorder in 50 to 60%. Conduct disorder, which is serious delinquency. These are the kids who often go on to have antisocial disorder, drug use disorders, promiscuity, get involved in criminality, etc. That rate is closer to 10, maybe 15%. Over to the left, it's very important to identify cognitive learning disabilities such as dyslexia or articulation disorders, and that's seen in at least 20 to 30%. Some samples are higher than that, some are lower, but at least 20 to 30%. It's something that you need to ask about during an evaluation. Over to the right are mood disorders. The most common mood disorders you're going to see in ADHD are depression, feeling down, sad, blue, and that often occurs in later childhood and early adolescence that you start to see the emergence of mood disorders. In a smaller percentage, depending on the sample and ascertainment, you may also see more severe rage attacks, manic-like symptoms, kids staying awake, not tired the next day, grandiosity, sometimes psychotic symptoms, breaking with reality, hearing things, seeing things. And those children may have a severe form of a mood disorder referred to as bipolar disorder along with their ADHD. At the bottom, the one that is the co-occurring problem or comorbidity that's often the most difficult to distinguish is anxiety disorders, and that happens in 30 to around 30% of kids. And it's something to be notable because internal restlessness and things of that nature may be difficult to discern. How do we assess ADHD? We do a life history with the parents. If you have the teachers available, great, but it may not be available, and it may be optional for adolescents where it's even more difficult. So I usually work with the parents, and then I have a Connors or some type of a rating scale that I can send back to get information from teachers through the parents. It's often hard to go directly, but it's not mandatory, but it certainly can help. And often parents will identify symptoms if teachers do, but it may not be the same symptoms. If you're working with young adults, you use self-reports or report through you. Do a mental status exam. How are you in terms of mood, anxiety? Is there substance use, something else going on? Rating scales can be helpful, and there's core rating scales that look just at ADHD, and then there's broad features. And there's a number of places that you can look for these rating scales, you can, for adults, for example, you can Google the World Health Organization ADHD, and they'll come up with some scales that are non-proprietary. The American Academy of Pediatrics has the Vanderbilt scale that's available also for rating ADHD. You'll be doing a standard medical history, including a cardiac and neurologic status, blood pressure, pulse. And if it's unremarkable, there's no need to do any further workup, no ECG, etc. And I've already talked a little bit about assessing for comorbidity. The next slide just shows you some of the ADHD rating scales and some of the sites where you can actually get these rating scales. And it's not mandatory. It can be helpful to have your favorite scale that's non-proprietary that you can copy and give to the parents to fill out on their kid or to the school to have available. And those are very, very helpful. Also give you some for adults. And again, these are all available through the references that are listed. Moving more kind of to treatment and stuff, I'm going to start by just showing you the next slide. That shows that studies show symptom reduction can improve functional impairment. If you look at symptom of ADHD improvement, what you find is independent assessment showing that people are doing better. And how much do you have to really reduce symptoms? You have to reduce symptoms by probably 30 to 50%. Before you can be satisfied that kids actually are feeling better about with their ADHD, that they're functioning better. We used to think 20 to 30% reduction in symptoms, and now we're thinking, closer to 40 to 50% reduction. So what do we do in terms of developing a treatment plan? The next slide, we want to educate people, including the child and the parents, about ADHD and what their strengths are and what things do we need to remediate. Set reasonable expectations for psychosocial treatments if you're using a behavioral modification or a pharmacologic treatment, and connect people with local and online resources, and then help work with the school, or if they're in work, to start making accommodations. Quiet work time, if they have processing speed issues or are struggling to get tests done in time, extra time. And then simple things like having them sit in the front of the class and working with the teacher to ensure they're recording the homework and doing the homework, and that you're getting feedback or the parent is getting feedback immediately, particularly if they're struggling, the child is, with their homework assignments. In terms of the next, developing a treatment plan, pharmacotherapy is considered first line with most of the new guidelines out. It may not be the first line, but it's considered among first lines. And in some cases, behavioral therapy, either parent training in younger children, which is indicated for young children, or for other kids, may be recommended if the ADHD symptoms are mild and you have minimal impairment and don't want to use medicines. You're not sure there's really ADHD, there may be a lot of anxiety, or pharmacotherapy is rejected. The parents don't want to use that, or the child absolutely refuses medications. Once treatment is established, a physician is also involved not only with just prescribing or recommending, let's say, behavioral treatment or go and this or that, but they may also coordinate with the school or college health to ensure that the treatment works between settings and preparing the patient for major transitions. So if you're working with a kid who's getting older and they're going to be going to work in the job market, what are you going to do for them? they're going to be leaving home, are you going to continue to follow them? Are you going to help set up some type of thing, reminding them about structure, reminding them to take their medications, reminding them that routine friendly and to be careful about their ADHD. So I think it's important to walk them through transitions, which is what we know is an area of difficulty for these kids, particularly what I call transitional aged youth, older adolescents and young adults, really a year or so in advance talking about that transition, and often if you can still follow them, that's great. The next slide, I want to just divert for a second and talk a little bit about activity levels in ADHD. There is data that indicates that enhanced activity, physicality, improves general attentiveness and executive functioning. Executive functioning being sort of time management, organization, shifting. And these are some programs, and you can take a look at your own, but they can be very helpful in terms of that. And it appears that activity through the day reduces hyperactivity. It improves the area of the brain that's involved in ADHD, the frontal areas of the brain in terms of blood flow and oxygenation. And the preliminary improvements are shown in ADHD. The effect size, or how well it works, it's considered a mild effect. So it has an effect. That effect has been replicated, so it's a real effect. And it's on the day that you do the exercise. So doing some exercise with kids is going to give them a mild effect and improvement in the ADHD. And I think that's good. Everything adds up when it comes to a chronic condition over time, and it reduces the burden of having to use psychosocial treatments or pharmacologic treatments. And then the next slide just reminds us that some of these cognitive functions that may be improved through activity but also otherwise is what I call that executive dysfunctioning. And here's just a list of different kinds: sustaining your attention, inhibiting the inappropriate responses, and the last one is really what it comes down to, organizing complex information. You have 3 or 4 things. You've got to organize it. You've got to prioritize it. And that can be very problematic. And oftentimes there's a dysfunction in that in ADHD. Now, executive dysfunction and ADHD are not the same. You may have ADHD without that. There are some kids with ADHD who are not at all impaired with that, and other kids who have ADHD who are significantly impaired in executive functioning and require additional work on these types of issues. And the next slide helps, again, point out other types of executive dysfunction, such as planning, the ability to say, I've got a big project to do and I've got to start working on it. These kids just may not have the capacity, and you may need to tell the parents, how do you help them with that? Or holding information in working memory. Kids who are sitting in class and the teacher says, remember, you have to do Chapter 5, but before you do Chapter 5, you have to go online and access this to be able to get to Chapter 5. They may not be able to put that in their working memory, especially auditory, things that are stated or written. They may not be able to hold that in their mind. So when they try to do Chapter 5, when they get home, they can't, and the parents are like, well, why can't you do Chapter 5? Because I didn't know that I had to do this online thing to really understand Chapter 5. In addition, there's also other cognitive functions such as learning disabilities, reading, math, sequencing, abstraction that we talked about. And particularly when you don't address neuropsychological comorbidity, it is associated with learning disabilities, school failure, poor socialization, and kids being held back. So what are some of the multimodal ADHD approaches in the next slide? There's support groups that we've sort of mentioned. One of my favorites is CHAD, and they have an online support groups and meetings and stuff, and a lot of dissemination of information. There's educational assessment and involvement. How is the child or adolescent, or if it's a college student, doing, and what things need to be remediated? There's organizational skills and coaching that can be helpful for both adolescents and adults. And parent training for younger children, so kids who go into with parent management, we'll talk a little bit about that in the next slide, but it will require some type of involvement, especially when they're younger in terms of working with parents. Psychotherapy can be helpful, and just to give you a sense, effect size is how well something works, and it's a technical term, but just to give you a sense, if you use, let's say, a stimulant for ADHD, an effect size is approximately 1. If you use behavioral modification without medication and you just work with the kid, if they're older or they're younger, with the parent and the child, the effect size is 0.3, and it can be particularly helpful for ADHD and anxiety or ADHD and oppositionality. We typically reserve specific insight-oriented therapies for other issues. So for general ADHD, it's not as particularly helpful, but if there's certain things going on in the family that seem to exceed the ADHD, then I would consider that. Let's go to the next slide, which is basics of parent management. And it's important to realize a few things that you can say in the office that really help. ADHD is structure friendly, so structure is your friend. Have the kids sit in the front, use the same kinds of approaches each time. Consistency, routine is good for ADHD. If parents are disagreeing about things, have parents talk to each other to have agreement. It's hard for the kid to get multiple messages, particularly if they have ADHD. Parents need to work closely with the school. Immediate feedback. Are there behavioral concerns or their academic concerns? This can't wait 6 weeks. It should be within a couple of days of the problems. Kids are forgetting their homework. They're struggling with this. They need to have this type of instant loop with the school. Parents should be careful about overreacting. Tell them to take a chill pill, take a deep breath, increase positive feedback. There's an older study, and I always that kids with ADHD get 11 negative comments for every 1 positive comment. Think about your own self. What would happen if you were getting 11 negative comments for every positive one? How long would you continue to do what you're doing? We've got to reverse that. And then promote activities that the child is proficient in or enjoys. Try not to remove them. So if a kid is a very good athlete, don't take that away if they're struggling academically. It's not clear that taking that away is going to help them academically, and now they're losing their self-esteem. So tell them, no, I want you to continue with your sports, but we're going to have to prop up or help you with this. If the kid is good at music or art, don't take it away. That's just going to hurt the child's self-esteem. It's going to take away from the child's sense of self-confidence and self-being, and we don't want to do that. I also tell parents to stay on top of the child's fund of knowledge. If the child is learning and you think they're having a good fund of knowledge, great, because sometimes the schools may miss something, and only the parent is going to pick up that they're really not knowing their math tables, they really don't know basic English, they're way behind in Spanish. Let the parent have some confidence that the child is learning the type of fund of knowledge that they would expect for that age range. In the next slide, this is looking at behavioral therapies, and the effective methods teach parents and teachers basically to use consistent rewards and punishment. So you need both. Kids doing well, you reward them. If they're doing things poorly or badly on purpose in particular, you punish them. But it's not a harsh punishment, but you need both reward and punishment for behavioral modification to work. So you can have brief timeouts. You can have a token economy, which is that you get reimbursed for doing well. And positive reinforcement for good behavior. But there's also a punishment component to it also. In the next study, it's important as we shift to medications to realize that medicines are important. And why do we say that? It's because there have been a number of studies. This is just one that's over a decade since it's been published that basically show that good medication management is critical for ADHD. And in fact, in this study, adding behavioral treatments to medication management was basically the same at 14 months and 2 years out, and exceeded the response to just behavioral treatment alone or community-based treatment. In this case, it was very well-titrated medication, and behavioral treatment didn't add a lot to that. So not all kids who have ADHD will require a full armament of both behavioral modification and medication. It also helps us realize you should not be apologetic about using medications, particularly in context to some of the things we talked about. The next few slides will kind of walk through the medications, and this next slide just shows you the pharmacologic treatments for ADHD and those that are FDA approved, including the stimulant medications, methylphenidate, again, an active constituent of a number of medications, dexedrine and amphetamine compounds, atomoxetine, which is Strattera, the antihypertensives, which are also referred to as the alpha agonists, including guanfacine and clonidine. And those are all FDA approved. And the antihypertensives / the alpha agonists, again, a lot of people refer to them now as the alpha agonists. They also are FDA approved in combination with stimulants. So that's one of the first combination treatments that are FDA approved. What is not FDA approved but has been shown to be useful for children in particular with ADHD are antidepressants bupropion, which is Wellbutrin, and the older tricyclics, as well as modafinil. These are not FDA approved but have been shown effective. The next slide focuses on methylphenidate in ADHD, and I'm just pointing this out. I'm not going to go through this in detail, but you can see the different dosages, the starting dose. What I want to point out are the maximum dose, and this may exceed FDA approval, but with methylphenidate in particular, you may need to increase the dose up to 2 milligrams per kilogram per day for standard methylphenidate, 1 milligram per kilogram per day for isomeric, which is Focalin, or the patch form, which delivers the medication more efficiently. How people typically choose the longer-acting stimulants is based on the duration. And for younger children, they may use a medication that has a duration of effect of 8 hours so that it doesn't affect later appetite and sleep. But for an older kid, they may want one that has a 12-hour duration. And that's typically how people are choosing the medications. They're all equally effective in terms of methylphenidate. It's which one has the duration, which one is generic and has, and can be used easily on the formulary. And there's a number of them now that are generic, including, let's say, generic methylphenidate, as well as, let's say, Oros methylphenidate, which is Concerta, that's generic, and some other ones now are coming off. And then for some kids, you may require lower dosages or to be able to titrate by 1 milligram increments. For example, a child who has Fragile X and ADHD, autism and ADHD, or a whole host of other things, in which case you may want to use the methylphenidate suspension. The next slide is amphetamine. AMPH is amphetamine, and here you can see there's a number, again, of different medications that are available. The maximum dose here, since amphetamine is more potent, is up to 1 to 1.5 milligrams per kilogram per day. With both methylphenidate and amphetamine, more methylphenidate than amphetamine, you may need to increase the dose after the first 2 to 3 months of treatment because there may be a mild tolerance. And again, you may see that with methylphenidate more than amphetamine, so that you may have done everything right with titrating, starting with a low dose, going up weekly until you get an effect that's optimal, not necessarily just the lowest effective dose, but what dose gives the best outcome with the fewest amount of side effects. And once you get to that dose, you may find, hey, the child's doing well, and then 3 months later, 4 months later, you get a call that they don't seem to be doing well again, in which case it often just necessitates the dose level increase. So if you're at 36 of Concerta, you may go to 54 of the Concerta or the Oros methylphenidate, which is the generic. And the same with amphetamine, the mixed amphetamine salts, also referred to as Adderall. You may go from 5 to 10 or 10 to 15. And it may just be that the child had a bit of a tolerance that developed. And finally, the last slide on pharmacologic treatments approved for ADHD include the non-stimulants, which include Strattera, which is atomoxetine, which has an up to 24-hour duration, and then Intuniv, which is an extended-release form of guanfacine, or Clonidine XR, which the branded name is Capve. And these all are non-stimulants. They're renewable. They work. They don't work quite as well as stimulant medications. They take often 2 to 4 weeks to get to the right dose, and it may take slightly delay to get the full effect of the medications. I'm just going to walk you through quickly a couple studies that are interesting to look at that you may or may not be familiar. A lot of people say, what's the lowest age you can use these medications in? And this is the NIMH preschool ADHD treatment study in the next couple of slides. And this one just shows you the design. Ages 3 to 5.5, they started with parent training. If any kid did well with parent training, they weren't included in the study. And then they did this elegant kind of lead-in with a double-blind placebo-controlled trial and then followed them over time. And in the next slide, you can see this is a large study. The methylphenidate in this study was given 3 times a day. And what's important to realize is that it did work for the ADHD, but it didn't work as well in the preschoolers, age 3.5 to 5, as it did in school-aged children. And the rates of side effects were higher. And this is interesting because in preschoolers, if used stimulants as with autism or Fragile X or kids who have severe cognitive decrement, you tend to see the same thing, less responsivity and higher rates of side effects. Just beware. The next slide, for pediatricians get asked this question all the time, what about the height and weight over time? And you can read this study, but the bottom line is that over time, there appears to be an attenuation of the height and weight effect. So some studies show a slight decrement in height, a greater decrement in weight over the first 2 to 3 years of treatment, and then after that, they escape that. And these children catch up in terms of height. Sometimes with weight, they're still a little bit less with their weight compared to where they would have been. But in terms of height, it appears when you look at these kids as they age through older adolescence into adulthood, they reach their ultimate heights and are very close on their ultimate weight. So there doesn't appear to be an appreciable effect on height and weight. Now, having said that, that's a group level effect. There are still going to be a few kids that have height and weight issues, and if you have much more than a 5, 6, 7-pound weight loss in a typically developing kid during the first few months of treatment, you may have to consider either adjunct therapy or changing the therapy to potentially, let's say, from a stimulant to a non-stimulant, or changing the type of stimulant. But for most kids who seem to be hanging in there, there appears not to be a subtle effect after 2 to 3 years on treatment. There may be initially, but not over time. And another big issue that came up was cardiovascular effects, and this was a large study that was published in the New England Journal of Medicine. There's a study both in adults and children, and in this study they looked at claims for cardiovascular and stimulant medications, and found that essentially that ADHD meds were not associated with adverse cardiovascular outcomes in children. And a similar analysis done in adults, published in the Journal of the American Medical Association around the same time, also showed no significant increases in adults with that, even those who had pre-existing cardiac claims. So it doesn't appear that these medications are cardiotoxic. Having said that, the next slide reminds us that if there are any concerns about cardiac issues, really what you want to do is ask about anything that puts kids at increased risk for sudden cardiac death, such as any previously detected cardiac disease, palpitations, chest pain. The one that sticks out the most is syncope and dizziness or seizures. Certainly a family history of somebody who's had a premature cardiac event at a very young age, or those kids who screen in positive on physical exam or blood pressure. I want to highlight that ECGs are not mandatory, and that comes from guidelines in pediatrics, although if you are concerned about something, it's certainly not restricted, but it may not be necessary. I would also comment that if kids develop chest pain, syncope, dizziness, or whatever during treatment, then they should be held off of their treatments and those kids referred. And we work with pediatric cardiology frequently at our site for kids who have cardiac malformations, who require treatment, et cetera, and we've had very good luck using both stimulants and non-stimulants in these kids, knock on wood, without adverse undue outcomes. What about other medicines? Atomoxetine Strattera is an FDA-approved medication. It's monotherapy, can be used as monotherapy. It can be used in kids who you want to just new start it because of maybe they have anxiety or something. It can be used in kids who don't respond to stimulants or have partial response, and there are data, although it's not FDA approved, to be used with Strattera and stimulants, so you can use both combinations, and that's been reported over many times in the literature. Kids who are not doing well on stimulants, or you're afraid because of stimulant diversion, and we'll talk about that at the end. Finally, we think it may be a really good medication for co-occurring problems with ADHD, sometimes, for example, tic disorders, or older kids or young adults who may have substance issues where you're afraid don't want to use a stimulant, or kids with oppositional disorder. And in the next slide, I want to show you a slide for atomoxetine for youth with ADHD and anxiety. And here you can see the red compared to the white. The red is active medicine reductions, lower scores are better. You can see it works well for ADHD symptoms as indicated on the ADHD-RS on the left, but it also helps with anxiety symptoms. In fact, it works as well for anxiety and ADHD as using one of the serotonergic medications such as fluvoxamine, Luvox, or others that have been studied for just anxiety. But again, atomoxetine may be the go-to medicine for anxious ADHD children. Other non-stimulants, this is guanfacine extended release, also referred to as Intuniv. It's a branded medicine. And what I want to point out here is that the dose that seems to be the best dose for kids is between 0.09 and 0.12 milligram per kilogram. That's the bottom one. So if you're using this medicine, the sweet spot of the medicine is 0.1 milligram per kilogram per day, which is typically a 3 or 4 milligram dose in a typical kid. We just finished and presented data in adolescents, and we found that adolescents requiring extended release guanfacine or Intuniv, the same thing, required up to 7 milligrams a day. And again, they did best at 0.1 milligram per kilogram per day. And it works for not only the hyperactivity and impulsivity, but it does improve the attention. The next slide shows a combination of Intuniv, guanfacine XR, with stimulants in the treatment of ADHD. And in this study, you could give the Intuniv at night at 7 p.m. or in the morning and give it to those kids who had partial response to stimulants being given in the morning, and it worked just as well. So either giving the extended release guan fasting in the morning or at night to kids who were receiving their stimulants in the morning worked well for ADHD, and it had an effect size of almost 0.4, which is a moderate effect over those kids who had just a partial response. So if you have a partial response to stimulants, and I would just say those kids who maybe have stimulants and mild tics or tics, you can use the combination of stimulants and non-stimulants, the alpha agonists in this case, and those are FDA approved. And the next study, the combination of clonidine XR, also referred to as CAFE, again, showing effect. Again, lower scores are better here, and you can see that using the active medication was significant compared to placebo and in stimulant partial responders. In this case, they all received the clonidine extended release in the morning and again at around noon. If we talk about treating co-occurring problems, which are referred to as comorbidity and ADHD, it gets a little tricky. And as a pediatrician, you may want to consider thinking about having somebody to refer to when you start getting into a lot of comorbidity. Simple comorbidity, if you feel comfortable, great. What we're recommending is that you prioritize treatment. So if you have kids who have severe mood or other issues, severe anxiety, treat that prior to treating the ADHD. So severe anxiety, obsessive compulsive disorder, very moody, you're going to treat that first. If you have an addiction, it's going to be really incumbent upon that the adolescent or young adult to have some addiction treatment, and then you can treat the ADHD. You don't have to wait for total recovery because you want to help them with the recovery by treating the ADHD, but trying to blast through active addiction is just not going to work. Consider psychotherapy. There's a lot of therapies that can be very helpful. So if you have an anxious kid, a cognitive behavioral therapy can be very helpful. The same with depression, and we have data that show that for substance abuse, it looks like substance abuse really responds to CBT. Consider medications with dual action. So in a kid with a lot of anxiety and ADHD, think of atomoxetine. If you have a kid with ADHD and tics, think of the alpha agonists or the antihypertensives. Again, that's the same medication. They just keep renaming them. If you have a kid with ADHD plus sleep, maybe you use clonidine. That'll help the ADHD and it helps the sleep. And then finally, you may use combined pharmacotherapy. To remind you, the bottom one, clonidine, guan fasting plus stimulants, is FDA approved. But you can also use atomoxetine plus stimulants off-label for those kids who require treatment for anxiety, ADHD, but doing with atomoxetine may not be sufficient. You add some stimulant on to help. Before we leave the pharmacotherapy, it's important to realize that stimulants have abuse liability. They can be misused by those individuals or diverted. And in fact, I just recently participated in a symposium where it was pretty clear to us that anywhere from 25 to 40%, depending on the kids you see, especially if you're treating older adolescents and college students, probably are misusing or diverting their medications. If you reverse it, about 10 to 20% of kids out in the general population of college students use stimulant medications non-medically. That's the bad news. They typically don't think they're dangerous, so they can use them. The good news is it's not the majority of them scamming it from local docs. They're getting them from their friends. They're not going in and making up, concocting diagnosis. Can't say that not all of them are doing that, but in general, that's not how it's happening. Most of the kids are using them for during college or school for concentration and alertness, and it appears to be occurring in substance abusers during academic decline. So in other words, they're not doing well. They are involved with excess marijuana smoking, alcohol, binge drinking, and then they start using stimulants to help prop them up. And we have data that show that about 30 to 40% of those who are doing that actually sort of get hooked on their own stimulant. And also realize there's an increased risk of SUD as substance use disorders in stimulant misusers. So they're linked. Stimulant misuse doesn't lead to substance abuse, but substance abuse may lead to stimulant misuse. So be aware of it. Tell kids to keep it safely away. Don't advertise they're on it. And remind them of the ethical issues of handing this medication out in college settings, that they need to be very serious about it. Don't keep it in medicine cabinets. Keep it in a chest of drawers, safely kept away. So the last slide in conclusion. Careful assessment of ADHD and associated psychiatric, psychosocial, and medical comorbidities is necessary prior to initiating treatment. Psychosocial interventions can be an important part of the treatment of children, adolescents, treatment with both stimulants and non-stimulants have been demonstrated to be both effective and safe. And most psychosocial and pharmacotherapy trials to date are short-term. However, we're having very encouraging findings with longer-term data indicating that they continue to work as long as the individual stays with the treatment and that there's tolerability. And I would add that from a neurobiologic standpoint, we're actually seeing improvements over time that we hope we can continue to replicate and find out. As a pediatrician, I would add, I think you have a lot to say about how a child does with their ADHD, the perception of ADHD, the family's involvement in ADHD, and that you can truly change a child's life by identifying and treating this through the lifespan, as well as realizing that this is a very rewarding disorder to treat when properly diagnosed and treated. And with that, I thank you for your attention throughout this